Welcome to this episode of the Good Grief Believer podcast. My name is Julie Craig. I'm the host, and I am excited to have with me three very special individuals. Dr. Alan R. Cohen, who is the Chief of Pediatric Neurosurgery, Professor of Neurosurgery, Oncology, and Pediatrics, and the Carson Spiro Professor of Pediatric Neurosurgery at Johns Hopkins University School of Medicine. He also serves as director of the Pediatric Neurosurgery Fellowship and the director of the Minimally Invasive Neurosurgery Laboratory and director of medical student education in neurosurgery. So, in other words, Dr. Cohen is a big deal, and we are so fortunate that he would give us some time. Dr. Cohen is also the author of a great new book that I'm excited to talk about. It is called Comfort Always: Healing in the Age of Technology. And joining me today is my daughter, Hannah Duarte, who is currently a medical student at the University of Utah, and her colleague, who is also a student, Sarah Heath, at the University of Utah. They're both medical students and both interested in neurology, and for Sarah, specifically neurosurgery. So this is going to be a great conversation to have Dr. Cohen be able to share his decades of experience, and especially the messages in his book, Comfort Always: Healing in the Age of Technology, with these upcoming medical students who are going to literally be moving this ball forward, especially in the field of pediatric neurology and neurosurgery, we hope. That's your objective. So, Dr. Cohen, I know I introduced you, but could you give your own life sketch and just a little bit about your background, how you decided to go into medicine, and other things that personalize you to this audience?
Julie, thank you for that very kind introduction. But in the words of Paul Simon, you could call me Al.
Okay.
And I'm a pediatric neurosurgeon, which is an interesting concept because I never even knew the field existed when I was in medical school, as your two guests are now. I was born in New York City, grew up in upstate New York, in Poughkeepsie, New York. And I was educated in public schools. Somehow I miraculously got into college at Harvard. I was influenced by my dad, who was an ophthalmologist, an eye surgeon. He was a very prominent member of the community, a gifted surgeon. I wanted to be like him. And I decided to go to medical school, but I didn't want to compete with my dad because I didn't think I could measure up to his standards. And so I went into neurosurgery because the brain is the ultimate mystery. The brain is probably the most complex item in the entire known universe. And I became interested in neuroscience and neurosurgery. And so that's what I do. And I was influenced by someone named Fred Epstein, who was a mentor of mine during my neurosurgery residency. He was a very gifted neurosurgeon, and I wanted to be like him. And so I chose a career in pediatric neurosurgery. I've been doing that for the past 40 years.
That's fantastic. And can I just ask you, what was it about Dr. Epstein that you wanted to be like?
He was a very charismatic guy, and he understood the human condition, I think. And he was a very gifted surgeon, but a very humanitarian person. And those were traits that I wanted to emulate. Sometimes people are born with that feeling of humility and humanity. For me, it was a learned activity. It didn't come easily, but it took time. And I wanted to be like Fred. I wanted to be like my dad.
I love that. I love the examples that you shared, because something that sometimes you hear people say is, I don't care what kind of bedside manner my surgeon has. I just want them to be the best. But maybe what you've discovered or hit on is maybe being the best is that combination of skill and humility and humanitarian concern, for the patient.
That was the intent of the book that I wrote. Basically, in this fancy age of modern technology, there's a tendency to forget the importance of the doctor at the bedside, and to remind people that if we do forget that, that means that technology can drive a wedge between the doctor and the patient and the family. And we need technology. Technology has allowed us to do things that we couldn't do even at the start of my residency training a few decades ago. But without humanity and humility and empathy and these softer aspects of healing, there would be no healing. So there's a combination of both technology and humanity. I think that's important.
I absolutely agree with you. And I'm so thrilled that you're getting this message out. I'm really excited that we're talking about this, because from the standpoint of grief, which is my specialty, my training is as a theologian. And so I specifically deal with people who are often grieving. There is that human component that can increase grief or actually lessen grief, depending on how we interact with each other. And so this is an important conversation, I think, for any healthcare provider to really, really stop and consider just what a pivotal part they play in a person's journey, especially when that journey culminates in the death of a loved one or the long-term disability of a loved one. It can make such a difference in their ability to deal well and grieve well. So thank you again. Thank you for being that kind of physician and for sharing your wisdom. And so that takes us to these young women. I'm so excited to have you both with us. And Hannah, could you start and just give a little background of yourself, who you are, how you decided to go into medicine, and what experiences you may or may not have had with grief?
Yeah, I can definitely hear a few similarities in my own journey. My dad was a physician, he was a dermatologist, and I inherited two very important traits from my dad. I love medicine, and I also am a patient. He was a patient, and that really informed the kind of physician that he was. When I was younger, about 8 years old, he was diagnosed with a pretty rare neurological autoimmune disease that severely affected the last decade of his life and our life as a family, both in negative ways and positive ways. I saw him grow and change in the way he interacted with others and the compassion that he had. And I wanted to be like my dad. I just thought he was a Superman. Like, I was so impressed with the way that he combined such intellectual vigor with also this deep compassion for people and really caring how they're doing. And I think medicine is at a really interesting crossroads between humanity and science. And so I've always loved that. And being a patient myself, I've had doctors who have helped and doctors who have made me feel worse. And probably with the same intentions of wanting the patient to do better and feel better. But the way that we deliver that is really what affects the patient's experience in the medical system. And so throughout just applying to medical school, now being done with my first year of medical school, neurology has been the most fascinating field for me because I love the patients, I love the science. I've been impressed with so many patients that I've met who, in a matter of overnight, days, hours, can have such different quality of life because of a neurological incident or otherwise, or an injury. And I've been really impressed with their perspective, with grieving the life that they had before and now stepping into a new life. I've been really inspired by them and I want to work with them. And the reason why pediatric neurology is specifically interesting to me is because I went to a pediatric seminar earlier in my first year, and I heard one of the attendings say, if I'm going to leave my kids in the middle of the night, it's going to be for someone else's kid. And so I thought that was the reason why I need to go into pediatrics, because if I'm going to be up in the middle of the night, leaving my own family, it's going to be for someone else's kid and someone else's family who really needs me in that moment. And so I love the field of pediatric neurology. I think it's changing every day. And I think the patients and the families are someone that we can all learn from so much.
I love that. Thank you, Hannah. Sarah?
Yeah, thank you for having me on. I'm excited to chat with you today. In contrast, I actually didn't know that I wanted to go to med school. I made that decision while I was in undergrad, actually. Hannah mentioned the intersection of the humanities and science, and I kind of knew I was looking for a career like that. I actually worked as a personal trainer, and I was getting my undergraduate degree in nutrition science. And so I was kind of looking at like personal training and dietetics. And as I was looking at those fields and some of the experiences I had, I could just tell that that wasn't the scope of practice that I really wanted to have. And so I got a job as a medical assistant in a neurosurgery and orthopedics clinic. And seeing the physicians work with the patients and the way that the medical teams work together, it kind of clicked to me that that is what I wanted to do. And so I decided I wanted to go to med school. And I came into med school biased because I had seen neurosurgery for 4 years working as a medical assistant.
Wow.
And so I came in and I started shadowing neurosurgeons here at the University of Utah. And Dr. Cohen, like you said, we have some great neurosurgeons here. And I ended up shadowing over at Primary Children's some of our pediatric neurosurgeons. And the patient population that we work with and the new technology and the developing sciences we can offer better treatments is really exciting to me. And so I think that that is the direction that I want to take my career. But also, yeah, I guess that's my introduction.
I love that. It's so great to have that range, you know.
Yeah.
I can still remember Hannah being about 6 years old and having a unit in elementary school about the human body. And it was like something inside her lit on fire. And she's been on this, straight trajectory ever since. But I love your story of experiencing life and trying different things, seeing where your interests lie, but then it almost sounds like it grew like a sunrise. Like all of a sudden it just became bright and sure, this is what I'm going to do. So it's good.
No, it felt like puzzle pieces clicking together a little bit once I saw this career path. So really exciting.
That's probably a lot like how you describe learning about the brain as well, like clicking puzzle pieces together, perhaps. So, Dr. Cohen, I've just really loved what I've read so far in your book, and I took all these different screenshots, things that I read that affected me. But you talk a lot about how technology has transformed medicine, but also that key component of compassion that cannot be replaced by technology. So can you give us just a little bit of understanding how you even came to write about this? What came together for you to say, this is something that needs to be addressed?
Well, it's interesting because you have two young, dynamic medical students now, and the field is much different today than it was when I first started. And as an academic pediatric neurosurgeon, I've written a lot and spoken a lot to the medical community about how we do our craft. My particular focus is in childhood brain tumors, and that's a very weighty topic. My time is concerned with prolonging life and forestalling death. It can be very, very draining, but very, very satisfying. And one of the things that struck me is that we now live in an age of medicine that's the business of medicine. And the doctor is considered a healthcare provider, and the patient is a client. And there's a business there. And I think, we have the electronic health record, the EHR, which was not in existence when I was in training. And it's done remarkable things. It allows us to put a lot of data in and transmit it around the world. But in some sense, this is also kind of a sterile coding and billing generator. And they have some crazy diagnoses now. You can type in, if you guys go onto the electronic health record, there's a code for other contact with a cow subsequent in or being sucked into a jet and being sucked into a jet engine subsequent encounter. It's the pendulum has gone so far in the other direction. And so what the purpose of this book was, this is the first time I've written for the general population, is to mention the fact that technology can do these remarkable things that couldn't even be done in the operating room when I started training. But over the past 40 years, it's come to my realization that technology treats the disease, but humanity heals the patient. And if we don't remember that part, then that technology can tend to drive a wedge between the doctor and the patient and the family. And it's important to remember that, because we want to embrace technology, but we don't want to eliminate the healing power of humanity.
I love what you said. I'm actually writing it down. Technology treats the disease, but humanity
heals the patient.
Heals the patient. I love that. I'm trying to envision. I'm envisioning a young couple. You assume, young family coming in with a child. How do you deliver a diagnosis that's going to change their life? Obviously their life's already changed. They're in a very, serious situation. They know something's wrong, but they don't know. How do you do that at the same time you're trying to write notes or, put in the right code for the clinical visit? How do you keep that connection with them in that moment? What do you find happens?
Yeah, it's a very interesting question. And it's one, if I had it to do again, with all the arduous training and the difficulties that my field has, I would do it again in a heartbeat. But one of the things that I have to do is meet with families and be the broker of probably the worst news that they've ever heard in their entire lives. And I have to say, I'm sorry to give you this news, but your child has a brain tumor. Because I know that it's going to change their lives and the child's life forever. It will never be normal again. And no matter how often I do it, it never gets easier. But with technology and advances in medicine and surgery, now many of the children with brain tumors who couldn't be cured can be cured, and those that can't be cured can have the disease controlled, and we can prolong life. And sometimes, very often, I get to be able to say, I'm glad to be able to give you this news. We were able to get the tumor out. It's benign, and he's going to be okay, or your daughter's going to be okay. And there's nothing that compares to that. The emotional intensity of meeting with a family after 8, 10, 12 hours of surgery and seeing the response. Everybody is upset, and there's always tears, sometimes happy, sometimes sad. But it's always very, very emotional. And there's no one way to do that. I think the answer to your question is that in these types of interactions, there has to be a balance between honesty and hope. And because there's a tendency, nobody wants to deliver bad news. There's a tendency to want to sugarcoat a situation, and nobody wants to do that, because the purpose of the doctor-patient relationship is to share the good and the bad. And you want to make sure that that bond is there to earn the trust of the patient and the family. And that balance of honesty and hope is different, but hope is, in my opinion, controlled optimism. And no matter how difficult the circumstance, there's always something positive to say, something to look forward to. Controlled optimism. Affirmative words can help healing. It's important to remember that.
I totally agree. Even that principle applies across the whole spectrum of life experiences. Because I can recall right after my husband passed away, it was so hard. It was just the hardest time. And I remember a friend of mine coming to my house. It probably was 3 days later. She came to my house her husband had been gone for about 10 years. All I knew of her was this vibrant, funny, happy hiking partner that I had. I knew her husband had died, but I didn't know, I wasn't there for her journey. But I remember her putting her arm around me, and she said, you know, for the first 5 years, she just felt awful, missed him all the time. It was so hard. And she said, and then one day I just woke up and the sun was shining. And I said to myself, how lucky am I that I was married to Joe? And for her, there was this huge shift that happened. And then her life looked like what I knew of her. And to have her tell me, you will not always feel the way you do now, knowing where she was in her life was so critical for me in a moment where I couldn't imagine ever feeling hope or joy again. And so I love this, that you're able to be with a patient in that most difficult moment, but also be able to offer hope. And your hope is informed. It's not a false hope. You've actually seen, miracles. You've seen reasons for people to find something to hang on to. Imagine it's just got to be so difficult.
And I think that the most important thing in the doctor-patient relationship is to build that trust, that no matter what the circumstance, we want the patient to want to come back and see the physician or the surgeon again, to share hope, to share disappointment, and build that trust. And there's always a way to say something positive, even in the most dire circumstances, trying to find a silver lining in even the darkest cloud.
I love that.
Yeah, Dr. Cohen, I'm curious, you talk about trust being built between the patient and the doctor. I want to understand how that works better. Do you have examples from your practice of how trust has been built in situations like this over time with families?
Well, again, I think there's no one way to do this. Every case is different, but there are the different softer techniques in building a relationship between a doctor and a patient involve empathy or compassion, caring, controlled optimism, hope, all these things, and humor as well. And the diagnosis of a brain tumor is something that's devastating. Many parents will want to protect their child because it's so scary to everyone, and they'll ask the kid to leave the room while we talk about it, and that sometimes can make the child more scared. We try to find out what the child wants to know, how much the family wants to know, and one of the arts of healing is that listening is something that we tend to forget. It's uncomfortable dealing in these situations where we're breaking bad or horrible news. And sometimes the most important thing we can do is just sit there and listen. Sometimes when there's silence, it's awkward, but that helps solidify the bond between the doctor and the patient and the family. So I think listening has helped. There's an oncologist from Toronto who died, Robert Buckman, who said, before you talk, hear. And you're listening, and you guys learned in medical school about the chief complaint, but you're also trying to use all of your senses to see what's going on in the room, the anxiety level, how much the patient and the family wants to know. And sometimes the parents who want to protect their kids learn that the child can sometimes help the family get through the ordeal. Some of these kids are extremely resilient, and the young child, I've seen that on more than one occasion, where the child helps the family get through this. So I think the power of listening is something that we tend to forget. It's very important. And then again, the power of words. Words can go a long way, and words can help heal. And so all of that, I think, is involved in that developing that trust between the doctor, the patient, and the family. And one of the things that I realize as an older pediatric neurosurgeon is that these are tough times to go through. But in this book, basically, I've used patient stories from my career. I've kept kind of a diary, and I've followed these patients through their lives. And now We continue to talk and email people from out of state or out of the country, but I get to see my patients now grow up and have kids of their own. And there's a tremendous joy in being able to do that. You develop a relationship between the doctor, the patient, and the family. And you're taught in medical school that, you need to distance yourself because in order to be an effective doctor, you need to be able to be rational. But I actually think that you don't want to distance yourself. You really want to be humble and be part of the whole ordeal. The good doctor, I think, tries to understand the disease and treat it. The humble doctor tries to understand what it's like to be a patient and have the disease and to heal the patient. And I think that's the difference. That's something that I think I've learned over time as a pediatric neurosurgeon over the past 40 years.
I love that. What do you think of that?
I love that response because it's nothing that we've heard before. Like you said, we hear so many ways of coping with the stress of being a physician. We hear, make sure that you have a support system. I think that's kind of like the running narrative right now is being a doctor is hard. Make sure you have people in your life that are there for you when you have to deliver bad news and such. And it makes me curious to know what your perspective is, because you talk about in your book this idea of comfort being an inner state, kind of a guiding force throughout your practice, both for you and for the patient. And I'd love to hear what your thoughts are between balancing your own comfort in a situation where you have to deliver bad news with the comfort of the most important person in the room, which is that patient. How have you done that?
It's something that is never easy, and myself and members of the medical team can go into a depression as we're dealing with the lives of people. Even when I have a mother operated on her child about 30 years ago, and we did an 11-hour operation. He was 7 years old at the time, and it was a benign tumor, and we removed it. For the 6 weeks after we did the surgery, she cried every day and every night. And now her son is an adult and just had a daughter of his own. And yet every time the mother speaks to me, we both cry. And that's a happy ending. And so, this has a lasting effect on people. And I think you just have to learn to cope with it. But I think rather than trying to distance yourself from the situation to remain rational, you want to really be empathetic and understand the human condition and understand what it's like. And by doing so, you actually become a member of the family. That's one of the unique things about pediatric neurosurgery. I had no idea about that. But the intensity is so great. We're not dealing with an ingrown toenail. It's the life of a child, the most precious possession that a family can have. And you bond, and they send cards and call and email. It's a really nice thing to do. It's a high price to pay, but the rewards are unbelievably great.
I love that. It reminds me of something that you said in your book. You do talk about the importance of humor. You touched on that. And you talk about strengthening that connection between you as the physician and the patient or the family. You said, let your guard down, make yourself more vulnerable. The rewards are powerful. I mean, and it's interesting that Hannah is saying, and Sarah's shaking her head, that they're hearing the opposite message. Distance yourself, find a way to cope. But what I hear from you is engage, be there, allow yourself to be a part of that journey. And that seems like one of those paradoxical ways that you avoid the burnout. Maybe it makes it more meaningful.
Yeah, I mean, humor is vitamin H, and humor helps healing. The Old Testament said that a merry heart doeth good like a medicine, and there's a truth in that. We deal with some of the most difficult concepts that we can ever imagine, but humor helps strengthen. It even strengthens the immune response, but it also allows you to, particularly, to develop a rapport with the child, and that's all important. And some of the silly things we do. We used to, when I was at Case Western Reserve, at Rainbow Babies and Children's Hospital in January, we used to get together and sing Elvis Presley karaoke songs. I would get up in a blue satin gown, rhinestone suit. These kids never heard of Elvis, and they felt as how they were fearless. And then one day, Good Morning America heard about this and said, "We're going to come film you." And I said, "Don't bother. We're going to hang up the microphone," because we were not really very good. And they came, and these kids were fearless, but they enjoyed it. And I think that act of being letting themselves go helps healing. I've seen it on multiple occasions.
Sarah, I'm curious, as you followed the neurosurgeons there at Primary Children's, are you seeing a correlation to what you're hearing from Dr. Cohen?
Yeah, I definitely am. Something though that is on my mind a lot as I think about this career, and Dr. Cohen, earlier you mentioned the business of medicine, and I do feel I think often about how I feel like speed and efficiency are prioritized, or just priorities that like the hospital system has. And in reading your book and hearing your stories, it sounds like, and maybe this is my perception, it sounds like those weren't pressures that you listened to, that you were able to step outside of those pressures. And I wonder if you can talk a little bit about that, because that's something that I'm really worried about in thinking about my career in medicine and these pressures that are going to be put on us.
You know, they're there and they come in different forms. And I remember in my training thinking it's very busy. We're dealing with life-threatening disease. And we have a list. We go in the morning. I have 3 brain tumors in the emergency room and 2 hemorrhages in the ICU and a spine fracture in the OR. And you think of the patient as a disease. And there's a famous quote from Maimonides from 1,000 years ago, who was a philosopher and a rabbi, a teacher, and a physician. And he said, "May I never forget that the patient is a fellow creature in pain. May I never consider him merely a vessel of disease." I think it's important to remember that, because it's easy in this business of medicine to think of your patient as an illness rather than a person. And I think that's the art of healing, to remember that you're not treating a disease. The technology can help do that, but it's the human touch that's going to heal the patient. And it's difficult to do that because life is busy. But the technology is definitely something that's helped us. We can do things with microscopes and endoscopes and exoscopes. We can look at tumors now on a molecular level and use agents to treat them with molecular personalized medicine that's more toxic for a malignant tumor and less to the body. But those are all adjuncts that are helpful, but it's that combined with the human touch that heals the patient.
So were you ever in a position where you were told you're spending too much time with the patient, you need to move it along, or were you able to leverage the fact that, look, what I can do, nobody else here can do. I'm going to take the time that I need. How do you balance that? Because you know the administration is, they're looking at the bottom line. They're trying to save money everywhere they can, and then you're trying to make a connection with the patient. Did you ever have any actual direct conflicts in that, or has it changed over time?
There are always conflicts now, and especially we have this fancy EHR, the electronic health record, and we can put data in it. But it also is a cause of burnout in physicians, because we spend time with the patients in the operating room, post-operatively in the clinic, and then in the evenings we have to enter all this data, and there's a lot of burnout with the electronic health record. It's definitely something that's been a major help, but it needs to be managed. The same is true with AI, the artificial intelligence coming down the pike at such a rapid pace. Some people, it scares the daylights out of. Are we creating tools that are going to be smarter than us and wipe out civilization? But it properly managed, it allows us to do many things that we couldn't do before. There's got to be a balance between this technology and humanity. It's hard to find that. What you want to do is find a way to project empathy, because it's a difficult word to describe. Empathy is caring or compassion, but it's it's something that if it's not there, the patient knows that it's not there. And everybody may express that differently. You have to try to find a way to do that. And it's only possible if you really feel it. And I think people who go into the field do so because they really feel it. That's what's important to get you through the long days and long nights.
You know, it's interesting. Even that principle of empathy does also then apply to those in a position where they are worried about the bottom line, right? You can have empathy for the fact that the administration is, they really are in a tight spot. Most patients don't realize just how slim the margins really are in medicine. You know, they see big numbers, they are charged huge numbers, you know, when they're in the hospital. And I think they assume that translates into, you know, just dollars falling from the sky into the pot of the hospital. But the hospital itself is constantly playing this game of lose money here, try to make it stretch here. And I think, just giving my own humble opinion, that principle of empathy works across the board in all phases of life, in every person that you deal with, from your auto mechanic to your hairdresser. You know, having empathy for the position that person is in and what they're trying to accomplish can go a long way. And I think you can find that when you show empathy to what a person is trying to do and are able to share with them, you know, from your experience, their experience, you listen to them, they'll listen to you. I think you might find that you get less pushback on some of these concerns when it comes to the business part, because I mean, it is necessary. A hospital will close its doors if it can't pay its bills, just like anybody else.
Yeah, it's important in lots of different areas, as you point out. And, you know, there's a story back in 1948, Life magazine ran a photo essay from W. Eugene Smith, famous photo essay called the Doctor. And it was about a guy named Ernest Sirianni, who was a country doctor in Kremlin, Colorado, a little bit west of Denver. And he had an area about 400 square miles, several thousand patients. He knew their names. He would go to their homes. They adored him. It was the country doctor. That we've lost some of that country doctor effect now, which is not to say that we should throw away the MRI, and the PET scan, and all the tests that we have, but to remember there is something that's at the bedside that tends to be forgotten. And that empathy, when it's there, is very, very powerful.
So taking this empathy, let's talk a little bit about your experience with the families who are facing an outcome that is not what anybody hoped for. Do you remember, do you have specific memories of doing that, maybe from your early career to your later career? What do you do with those families when you know you're telling them this child will not survive?
Even in the most dire of circumstances, there are always things that we can do. And I think it's important to remember that. That is, words can help heal. And even if we can't cure someone, we can often prolong life and we give people a good quality of life with some of the technological adjuncts that we have now. And there's always something else that can be done. We can try another medication. Pain can be controlled. There are different chemotherapy drugs that are becoming more effective that can be done. And we just want to be there and share the hope and share the disappointment, but not give a false hope. So it's just something that's very common right now. But you know, the title of the book that I use is "To Comfort Always." It comes from a phrase to cure sometimes, to relieve often, to comfort always. It was from a 1500s surgeon, Ambrose Paré, a French surgeon, one of the fathers of modern surgery. And I think it's that we can't always cure. We can do a lot more than we could before. There are tumors that were fatal when I was starting my training that we can now cure. But even when we can't cure, we can often control. And it's some of the simple things that you do at the bedside. We've lost this aspect of bedside diagnosis and bedside manner. But some of the simplest things that you do just by sometimes sitting there and even in silence, you create a bond with the patient and the family, or you adjust the pillow, or we put a little dressing on the bunny rabbit, the stuffed animal, to let them recover at the same time as the kid does. Some of the simplest things we do are the ones that are remembered by the patient and the family. And so you just want to have that trust and be there for the good times and be there for the tough times.
I really like what you said about when we can't cure, what can we do to treat? What can we do to help you live? And this is not on par with a brain tumor. But when I was diagnosed with Crohn's disease, one of my major questions as a patient was, what is my life going to look like now? What can I still do? How is my life going to be different? I was so scared that the plans I had made for my life would not be able to be realized anymore. And I think one of the responses I got a lot was, life can still be good. It's just going to look different. And now that I'm past some of those more emotional beginnings, I see the value in that. But in that moment, I didn't appreciate it and I didn't feel comfort in it. What are some things that you've said or strategies that you've come from to help a patient see value in their own life, even when it looks different with a diagnosis?
Yeah, I think that one of the issues is that words are underappreciated as an adjunct in the doctor-patient relationship. And affirmative words can help healing. And again, there's no one way to do it, but it's just that you want to make sure that the patient, when the patient leaves the hospital, when there's a problem, they want to come back and you keep that bond. And it's different for every patient, different for every disorder that's there.
Anything else that you've been curious about, Sarah, that you wanted to ask Dr. Cohen?
Yeah, it sounds like a lot of what I'm hearing is that time and listening and attention are respect for the patient, and that you have really prioritized giving your patients that respect through your time. I wonder if there are any habits that you built in to help you prioritize that, maybe before you step into a room, or how do you stay grounded in giving that time and that respect to all of your patients?
Well, there's never enough time. That's one of the problems. And we make rounds. We work with a team. So I have a team of surgeons that I work with, trainees and colleagues, and we have oncologists, the medical experts who are experts in delivering bad news. It's an art that you develop over time. There are neurologists, intensive care doctors, patient advocates, the bedside and nursing staff. There's a whole team that works together. And what happens is even if you have a family that's medically sophisticated, when you give news like the diagnosis of a brain tumor, much of what you say does not get heard. And so repetition is important, patience is important, and going back again to explain it. But I think when you leave the bedside, the main thing you want to make sure is that the patient does not feel abandoned, that they know that you'll be there again. But it's amazing because the anxiety level is so high that even sophisticated people will not remember some of the basic things that get said. And so you do it again and again and again. And that's how you develop that rapport.
I love that. I was curious about the same thing. I was wondering, you've talked about the influence that your father had and that Dr. Epstein also had on you. Where do you access what makes you you? Where does this come from? Is it just from these great examples? Is there what do you access in your personal life that gives you this fortitude and compassion?
When I was a young kid growing up in Poughkeepsie, New York, we didn't have video games and things that they have now. We would go out and play baseball and touch football and basketball and cops and robbers, games like that. And we had a friend, Stewie, who was a young boy. This was very early elementary school, nice guy. He hung out with us, and one day he wasn't there, and then he came back, and he looked pretty pale and ashen. He'd lost weight, and then he was back in school, but he continued to be sickly appearing. And then one day he was gone, and I was very young, and we were told that he died. And that was my first encounter with someone who died, and I didn't understand it. It was kind of scary. He had bone cancer. I later learned that it was Ewing sarcoma, which is a very tough tumor, and that now can be treated and controlled and sometimes cured in some cases. But he disappeared, and it affected me. And I thought about it, and now years and decades later, I think about him often in the field that I'm in, because what we're trying to do in neurosurgery, and pediatric neurosurgery and brain tumor surgery, is to cure the patient, to heal the patient, to prolong life. But if we can't prolong life, we want to prolong the quality of life. And so we focus not only curing, but sometimes prolonging life with a good quality of life. And I hope Stewie had a good quality of life. Now there have been improvements in the treatment as well. It can be a tough disorder, but I think for those who survive and are not cured, we also concentrate on the quality of life. That's what I try to focus on.
I love that. So what I'm hearing from you is that a lot of what came into making you is these early experiences with compassion and care. You had a connection with someone who you lost, and so you can access what that feels like in other people. And so that makes me wonder, Sarah, where is that for you? Where does that come from? You know, other than the brain being fascinating, there's got to be more to it. It's too hard what you're doing for there not to be something inside of you that is motivating you. And I'm curious to know what that is.
Maybe it's unknown. I really don't know myself. Some people go into the field of neurosurgery because they had a relative who had a brain tumor, or go into neurology because they had someone who had Alzheimer's disease, and they go into research to try to help find that. I think I just kind of stumbled into the field, and it was a lucky move for me. And it was very hard because the hours of training that's arduous. But the payback is something that you just can't appreciate. Even on the most fancy television shows, you can't get a grip of what the emotional intensity is when you're dealing with patients and families, and being able to send a little kid back out of the hospital and see him come back alive.
I love hearing that. That is very similar. While I was in undergrad, I volunteered with hospice for 4 years. And so, like 2 times a week, I would meet with whichever patients I was working with at the time. And the reason I've been reflecting on that during this conversation is because it was very similar. I was an undergrad. I was really barely part of the medical team, but what I got to do was sit with the patient. And we were mentioning like just giving them time, the power of words. And that was all I had to offer, but it was so meaningful to both the patients I was working with, and it was really meaningful to me. And I saw how important it was to them. And so I've loved being able to hear your stories, Dr. Cohen, and just hear how that continues in your career and how you're able to offer that in a range of different situations.
And many times, just that presence that you had there is something that's remembered by the patient and the family. They come back and ask, "Oh, where's Sarah now? We miss her because of what you did." Just the act of being there. Sometimes even friends and family dealing with families who have a child with a brain tumor are afraid to be there because they don't know if they're going to say something wrong. They're nervous about it. They haven't encountered it before. But just the act of being there can help healing. And I think that's what's important, just being there.
Yeah.
I think that gives a lot of insight into one of the things that you and Hannah both mentioned before. they're putting all of this emphasis on having your care team in place, right? But maybe so much of this to avoid burnout is being able to continue to access what it was inside of you that allowed you to sit by somebody's bedside while they were in their final days. And there's something holy there. There's something truly holy in being that intimately involved in a person's life. And that is actually energizing. I mean, you can get tired, right? You have long days. All of that is real and true. But maybe avoiding burnout is possible because of making connection.
Connections are very powerful. And what I found is that I try to sleep during Zoom meetings when I turn the camera off. That's our secret.
That's funny. Well, good thing we have the camera on. We can see you. Well, so one thing I wanted to ask you, Dr. Cohen, as someone who has a front row seat with so many families going through these difficult things, what have you seen in certain families that you believe has allowed them to grieve well or to receive the information well, especially those who eventually lose their children? What do you see that sets them apart from those who maybe suffer more?
It's a very difficult time for people to have a child with a brain tumor. The divorce rate of families in that situation is high. And grief, it's a normal part of life. I don't think there's a magic formula, but if there is a underlying problem with the family beforehand, it certainly gets magnified at the time of a serious illness like this. And I think just trying to be part of the team and not trying to drink the ocean, take it one day at a time, and develop the trust with the healthcare providers that are there, the doctors and nurses and ancillary staff. If you can have that trust, then you have someone to lean on, and I think that can be very helpful.
Agree, that's insightful. Hannah, Sarah, was there anything else that you were curious about that you'd like to ask Dr. Cohen, or comments you'd like to make?
I definitely wanted to talk about family dynamics with children who suffer. That was something that I really wanted to know more about, because when I've talked to pediatricians and discussed things with them, they talk about how you don't just have one patient. You don't just have the child who is suffering. It's unique in the way that you support an entire family. So how can that be done really effectively? How can I make my patients' families feel like I'm someone that they can rely on and be there as a support system when they need it?
Yeah, I think one of the things is to let the family be there. They restrict the number of people that can be in a room, but when their younger or older brother or sister comes in, that helps heal. And a lot of kids actually do remarkably well as they leave the hospital and get home to a familiar environment. So we can take out a brain tumor and we give all sorts of medications and steroids and antibiotics, anti-seizure drugs, and the patients in the hospital, and they can be pretty sick. And then the day they go out and go back to their home, to the familiar environment with their siblings, they improve dramatically. Home, just being home, is helpful.
Well, Dr. Cohen, this has been a fantastic conversation, and I'm so thankful for the time that you've set aside, and for our two young medical students. Thank you so much for coming and engaging in this conversation. You're the hope. You're the hope for the future. Families that don't even know how instrumental you're going to be in their lives they're already existing, probably raising kids. And I really believe that what Dr. Cohen has shared with us, especially in his book, Comfort Always, is going to be really instrumental as you navigate your careers and interact with patients.
I think that actually Hannah and Sarah are going to be the hope for the future. And I think it's just important to remember as you're going through these tough days in medical school that there is something that can be really powerful at the bedside, the doctor-patient relationship, something, history and examination at the bedside can cut through a lot of the data that we get. It's so overwhelming with all the blood tests that we do, but just sometimes good common sense and compassion go a long way. And I think if I were to leave you with anything, again, it's that technology treats the disease, but humanity heals the patient.
I really appreciate that. I appreciate your advice, and I appreciate the reminder that this conversation has been about the honor that it is to play a role on the care team and with these patients.
Yeah, I know Sarah and I are working hard right now, and it has been really helpful to hear the greater perspective of the work that we're doing, and that there are people that are going to rely on us, and that we can be prepared as human beings to be with human beings as they're struggling and grieving. And it really is an honor, just like Sarah said, and you inspire both of us so much to do that in such a human-like way, in such a compassionate way.
I love that. I love that. And as the physician in a room in the care team, you are the one that ultimately everyone else is looking toward. And I think you can teach by example. You can set the tone for the rest of the care team by how you approach them. And yeah, I think they're going to be great, don't you, Dr. Cohen?
They're going to be great. Just keep it simple. Work hard and be nice to people.
There you go. There you go. That is universal. We had a sign said that every time one of the kids walked out of the bathroom door, that's what they saw: work hard and be nice. we're going for assimilation. You'll be assimilated. We always end this podcast asking the question, what do you think it means to grieve well? And I think I would like to ask each of you, Sarah, Hannah, and then Dr. Cohen, could you just share your thoughts? What do you think it means to grieve well?
I don't have a lot of personal experiences with grief in the same way that it sounds like other people might. I have seen people be changed by grief, and I really admire the way that I have seen people grieve and be changed by it. And so I guess that would be my answer is I think that people grow through the process and come out different. And yeah.
Thank you.
I actually think what Sarah said is really profound. Coming from a perspective where I've seen people grieve, I've grieved the loss of my dad at just way too young of an age. And I wish I could have told myself when that was happening to allow it to change me. I think that we get scared that grief, in whatever form, if it's grieving a life or an ability that we used to have that we no longer have, or if it's a person, I think we get scared that it's going to change us and it's going to harden us. And I would instead invite the change. Let it soften you. Let it teach you things that will drive you in the way that you interact with people going forward. And that's a very different perspective than I had 5 years ago when my dad passed away. But I'm grateful for the changes. Like Sarah said, it can change you for the better. And that's what I think it means to grieve well at this point in my life.
I agree with both of you. I think for people who haven't experienced it, grief can be scary. There's a fear. And I think the important thing is it's a part of life, so let it process and be yourself.
Thank you so much. Wonderful conversation. I appreciate all of your time.